Usually when we talk about a medical diagnosis, there is a fundamental expectation of precision, right?
Right, absolutely.
You look at a radiograph, the bone is fractured, you see the jagged white line, and you point to it.
Exactly. There is the pathology.
Yeah, there's the pathology, there's the plan. I mean, we operate in a world of algorithms, clear diagnostic criteria, and, well, objective truth.
We do.
But then you step out of the theater, you take off the scrubs, and you enter the landscape of your own professional life.
Yeah.
And suddenly all that engineered precision it completely vanishes.
Spot on. It just evaporates.
Welcome to Deep Dive Ortho. Today we are wading into diagnostic muddy waters, not for our patients, but for ourselves.
Yeah, the hardest patients of all, really.
Truly.
Yeah.
So I want you to picture a highly specific scenario. You are sitting in your car in the hospital car park. The engine is off.
We've all been there.
Oh, definitely. It has been a 12-hour shift, perhaps an exhausting on-call weekend, and you are staring at the steering wheel. Sitting in the passenger seat next to you is a heavy, unmade decision.
A burden. Yeah.
Maybe it is a stalled career move you have been agonizing over for, say, 6 months. Maybe it is a leadership commitment, like taking on the role of clinical director, that you desperately want to decline.
But you feel you can't.
Exactly. You feel you cannot due to departmental pressure. Or perhaps it is a quiet, persistent internal debate about whether you are even in the right clinical role anymore.
Yeah.
You tell yourself you will figure it out when you have a weekend off or when the current waiting list crisis subsides. But the time passes, the clinical demands never lessen, and the clarity, it never comes. You just keep carrying it.
And the carrying itself becomes a chronic, low-grade pathology.
Wow, yes, a pathology.
I mean, it drains the cognitive reserves required for everything else. What we are observing in that car park scenario is essentially the central paradox of the medical profession.
Which is what, exactly?
Well, clinicians make hundreds of incredibly high-stakes, complex decisions every single week. You guide patients through terrifying oncological diagnoses. You navigate trainees through intricate surgical reconstructions.
Right. You constantly weigh risk, morbidity, mortality.
Yeah.
Yet, when it comes to personal professional choices, that same highly trained mind completely stalls.
It just freezes.
Completely. There is almost total isolation and, more importantly, a complete absence of a structured framework.
And that is the mission for this deep dive. We are synthesizing cognitive behavioral research, clinical psychology frameworks, and observational field notes on executive decision-making to unpack a highly practical, structured methodology for self-coaching.
Which is so desperately needed.
It is. And let us define our terms right out of the gate here. We are not delving into psychotherapy today.
No, not at all.
We are not discussing the merits of hiring an external executive coach for a 6-month program. We are focusing on mastering the mechanics of the internal conversation.
Right.
The goal is to take a professional decision that is completely stuck in the cognitive mud and apply a rigid structure to drag it out into the light.
And that requires abandoning the prevalent myth that time alone produces clarity.
Yes. We always say, I just need more time to think. Exactly. But time just produces avoidance. Structure produces clarity. I mean, the default strategy for highly intelligent individuals, especially surgeons and physicians who have relied on their intellect to pass every exam and solve every clinical problem, is simply to think harder about the dilemma.
Right. Just power through it.
Yeah, they assume that if they apply enough mental horsepower, the answer will inevitably reveal itself. But pure thought fundamentally fails when it is directed inward without constraints.
Because it's a completely different environment.
Precisely. The cognitive paralysis experienced in that hospital car park is never a failure of intelligence. It is a failure of architecture.
I love that phrasing. A failure of architecture. But before we apply any architecture to solve the problem, we need to dissect why that default strategy fails.
We do.
Because we are explicitly selected for our ability to process complex, multi-layered information. We do it daily in multidisciplinary team meetings. Why does turning that same analytical processing power towards our own career trajectory result in a system crash?
Because the brain is not a sterile operating theater. When evaluating a patient, for instance, assessing an 80-year-old for a complex joint revision with multiple comorbidities, you operate with objective distance.
Right, you're looking at the scans, the bloods.
Yeah, you apply established algorithms, you are insulated by professional boundaries, but the moment you turn that intellect inward, the structures collapse because the observer and the subject are the same entity.
You're diagnosing yourself.
Exactly. The cognitive environment is loaded. The neural pathways are flooded with ego, hidden fears, deeply ingrained loyalties to a specific NHS trust or your immediate colleagues, and massive self-image concerns. You are attempting to be the judge, the prosecution, and the defense simultaneously.
So the analytical mind we rely on is essentially functioning as a compromised jury.
Very compromised.
It is attempting to weigh evidence while actively being manipulated by its own biases.
It is worse than a compromised jury, actually. It is a jury actively being blackmailed by the amygdala. I mean, when attempting to think through a hard personal decision, the brain involuntarily pulls in all the emotional variables that make the choice terrifying in the first place, and it simply spins them in a loop.
Like a washing machine.
Exactly.
Yeah.
It is a phenomenon tied to the default mode network in the brain, which activates during passive rest and rumination. You circle the issue without ever penetrating it.
Right.
Furthermore, unstructured thinking relies heavily on abstraction. A clinician might spend months asking themselves, should I leave my current hospital? That is not a decision. That is a philosophical topic.
That's a huge distinction.
It is. You can ruminate on a topic for a decade without ever moving a single inch forward.
It is akin to a consultant who can flawlessly template a complex pelvic osteotomy, calculating the exact angles of correction, anticipating the soft tissue tension, mitigating the risk of nerve injury.
The mechanics, yeah.
Right, all the mechanics. But they entirely freeze when attempting to restructure their own private practice schedule. The complexity of the task is not the barrier.
No, not at all.
The proximity to the self is the barrier. But let us drill down into that distinction you just made. What's the functional difference between contemplating a topic and actively evaluating a decision? Because when you are in the middle of it, pacing around your living room at midnight, they feel metabolically identical.
They feel identical because both processes consume vast amounts of working memory and, well, they generate anxiety, but only one has an actionable endpoint.
Okay.
Contemplating a topic is vast, nebulous, and boundaryless. Questions like, am I happy in my surgical subspecialty? Or should I do more private work to ease the financial burden? They invite endless circular debate.
Because there's no deadline.
Precisely. They lack temporal constraints. Actively evaluating a decision, conversely, requires absolute specificity and a firm deadline.
Give me an example of that.
So instead of, should I do more private work, it's, do I accept the partnership offer from the private clinic on Harley Street by the 30th November, or do I remain full-time in the NHS? That is a decision.
That forces your hand.
It does. Unstructured internal reflection will always veer away from the most uncomfortable questions. The brain masks avoidance by disguising it as deep, profound thought.
Masking avoidance as deep thought. That is an incredibly uncomfortable mirror to hold up.
It is confronting, isn't it?
Very. We convince ourselves we are being profoundly reflective and taking the choice seriously,
Yeah.
when in reality we are just pacing safely around the perimeter of the actual threat.
Precisely. And because pure internal thinking leaves no physical trail, weeks of this intense rumination yield absolutely no cumulative progress.
None at all.
You can agonize over leaving your clinical lead role for 2 hours on Monday, experience a slight revelation, fail to document it, and by Friday, the brain has completely reset the loop.
You're back to square one.
You start the anxiety cycle entirely from scratch. The working memory simply cannot hold the emotional weight and the logical variables simultaneously without dropping something crucial.
Which brings us to the actual mechanics of the intervention. Because unstructured thinking is hopelessly compromised by our own neurobiology and biases, we have to impose an artificial framework.
We do.
A rigid set of questions designed to force specificity and override the default mode network. We need to define the actual parameters and, critically, uncover the hidden drivers of the choice. Let us dissect the first two questions of this 6-question framework.
Okay, let's get into it.
Question 1 is, what is the actual decision I am avoiding? As we just established, this is the forced transition from an abstract topic to a highly specific, time-bound choice.
Forcing the abstract into the concrete is the foundational step. You must isolate the variable. But the second question is where the profound psychological excavation begins.
Okay, what's question 2?
Question 2. What am I afraid of about each option? The critical operative word there is
Each option.
Yeah, you must forcefully articulate the fears attached to both sides of the decision, not just the disruptive path you are trying to avoid.
Now, I'm going to challenge the clinical utility of that. Go ahead.
If you have a clinician who is already paralyzed by a decision, let us say a mid-career surgeon, staring down severe burnout, and contemplating stepping away from the operating theater entirely for a role in medical technology.
A very common scenario right now.
Right. Doesn't forcing them to list out the terrifying aspects of every single option just compound the cognitive load? Doesn't amplifying the fear just trigger the fight or flight response even harder, making them want to abandon the framework and hide under a blanket?
It is a completely rational assumption that focusing on fear will amplify it. However, the neurobiology effect labeling proves the exact opposite occurs.
Really?
Yeah. The foundational principle here is that fear unnamed is fear running the decision invisibly.
Unnamed fear.
When a fear remains vague, unarticulated, and floating in the subconscious, it takes on a massive existential weight. It feels like an impending catastrophe.
It feels like the end of the world. Exactly. But when you force the brain to articulate it in language, when you write down, I am terrified that if I leave clinical medicine, my colleagues will view me as someone who couldn't handle the pressure. Or, I am terrified that if I stay, the chronic stress will trigger a myocardial infarction. You fundamentally shift the processing location in the brain.
Oh, that makes sense.
You move the fear from the amygdala's primitive threat response to the prefrontal cortex's analytical linguistic processing center.
You are essentially taking an invisible systemic infection and localizing it into a visible abscess that can actually be drained.
A very clinical way to view it, but highly accurate.
Thank you.
The option a clinician is naturally leaning towards usually carries its own set of terrifying prospects that are actively being ignored to maintain the illusion of a safe choice.
Give me a clinical example of that.
Let us examine a surgeon leaning heavily towards remaining in a highly toxic, understaffed department because it is familiar.
The devil you know.
Right. The fears of leaving are glaringly obvious. Loss of institutional prestige, disruption of routine, immediate financial uncertainty, the sheer effort of building a new network. Those fears are loud.
Very loud.
But the fears of staying are often suppressed. They might be. I am afraid I will become permanently cynical, lose all empathy for my patients, and despise the career I spent 20 years building.
Wow, yeah, that's heavy.
Making those implicit fears explicit strips them of their existential dread. It converts them from a vague sense of doom into defined, manageable risk factors that can be systematically mitigated.
It is about dragging the monsters out from under the bed and putting them under the harsh glare of the operating theater lights.
Exactly.
Once you see that the monster is actually just a definable pathology, a specific risk of reputational damage, or a specific financial shortfall, you can formulate a treatment plan. You cannot treat a shadow.
Spot on. You can't.
Okay, so the parameters of the specific decision are locked in, and the hidden fears on all sides have been dragged into the light. We now transition to the second phase of the framework, which deals entirely with perspective and time horizons.
Yes, phase 2.
Question 3 asks, what would I tell a friend in this exact situation?
This is arguably the most devastatingly effective psychological lever in the entire framework. Asking what you would advise a friend relies on a concept known as Solomon's paradox.
Solomon's paradox.
Yeah. It deliberately suspends the ego and the self-image stakes. As medical professionals, clinicians are highly trained to assess complex risk, synthesize conflicting data, and provide clear, actionable guidance.
That's our day job.
It is. You give remarkably lucid, objectively correct advice to your peers about the exact same professional dilemmas that completely paralyze you personally.
It is astonishingly true. If a fellow consultant comes to me and says, I am working 80 hours a week, my clinical director is actively undermining my surgical waiting lists, and I am developing chronic insomnia, I do not hesitate for a microsecond.
Not for a second.
The path is obvious. I tell them, you need to step down from the extra lists, protect your GMC registration, and aggressively seek a healthier clinical environment.
Right, it's black and white.
But if that exact scenario is happening to me, the narrative completely changes. I tell myself, well, the department is under pressure. If I just work a little harder, I can fix the culture. I need to show resilience, and I certainly do not want to be perceived as abandoning the team.
And look at the difference there. The intellectual capacity to generate the correct healthy solution is perfectly intact in both scenarios. The cognitive machinery works.
So what's breaking down?
What is missing in the personal scenario is the willingness to accept the advice. Taking the advice means confronting your own deeply held ego, your perceived tribal obligations to the hospital, and your core identity as an indefatigable, resilient doctor.
Which is painful.
Extremely painful. By framing the problem as advice to a respected colleague, you introduce psychological distancing. You bypass the ego's elaborate defense mechanisms and directly access your own clinical wisdom. You remove the emotional contamination from the data.
It is a phenomenal cognitive bypass. You
Yeah.
trick your brain into treating yourself with the same compassion and objectivity you reserve for your patients and peers.
That's exactly what it is, a trick.
Moving to question 4. What would I regret in 5 years if I didn't do this? And conversely, what would I regret if I did? The underlying theory is that shifting the time horizon filters out immediate trivial friction and services deep core values.
Right.
But I have to push back on the functional reality of the 5-year regret metric.
Okay, let's hear it.
Healthcare, particularly within massive systems like the NHS, is in a state of constant volatile flux. Funding models change, Royal College guidelines shift, waiting list initiatives come and go, not to mention the unpredictability of our own health and family lives. How can any clinician accurately predict their 5-year regret when the landscape is essentially written in sand?
That is a highly pragmatic challenge, but it misinterprets the objective of the question.
Oh, how so?
The goal of the 5-year horizon is not to forecast the infrastructural or political reality of healthcare. It is an exercise in temporal discounting. It is designed to predict the trajectory of your own internal values.
Okay, give me a concrete example.
Let us look at a mid-career orthopedic surgeon who is advising a junior colleague on stepping down from a prestigious but highly toxic regional training committee. In the immediate term, say, the next 3 to 6 months, the friction of stepping down feels immense.
Huge friction, yeah.
There will be deeply uncomfortable conversations with senior mentors, awkward handover documents to write, whispers in the department, and a temporary sting of professional embarrassment.
And nobody wants to deal with that.
Nobody. If the brain only calculates the short-term reality, avoiding that immediate social friction always seems preferable. The brain will always choose the path of least immediate resistance.
The short-term goal is purely survival and conflict avoidance. The brain just wants to avoid the awkward meeting on Tuesday.
Exactly. The brain is reacting to a social threat as if it were a physical predator. But when you force the timeline out to 5 years, the immediate friction dissolves into insignificance.
Because Tuesday's meeting doesn't matter in 2030.
Exactly. In 5 years, you will not even remember the awkward phrasing of the handover email. You will not care about the temporary departmental gossip, but you will absolutely, profoundly feel the regret of having wasted 5 of your peak cognitive and surgical years in a bureaucratic role that caused you moral injury.
That hits hard.
Or, conversely, you will feel the immense compounded relief that you reclaimed your evenings to focus on your young family, or redirect your energy into a clinical fellowship you actually care about. The 5-year horizon silences the noisy, panic demands of tomorrow and forces you to confront the long-term shape of your character.
The shape of your character. It is exactly like treating a pediatric spinal deformity.
Oh, I like that analogy.
When you are looking at a scoliotic curve in a 10-year-old, you are not just treating the degree of curvature presenting today. You have to project the biomechanics.
Right, we're looking ahead.
Exactly. What is that curve going to do to the entire thoracic cage in 5 years during a major growth spurt? You have to intervene based on the trajectory, not just the current temporary presentation.
That is a flawless translation of the concept. You are applying your highly developed clinical foresight to your own personal values. You are treating the trajectory of your life rather than putting a plaster on today's social anxiety.
We have established the parameters, exposed the fears, bypassed the ego, and shifted the timeline. The framework now enters its third phase, exposing blind spots and unblocking action.
The hard part.
Yeah. Question 5 is the most confronting. What am I not letting myself see? This requires a level of brutal self-honesty that most of us spend decades avoiding.
It is deeply uncomfortable because it addresses motivated blindness. It forces an acknowledgement that the chronic delay in decision-making is rarely due to a genuine lack of data.
It's not about gathering more information.
No, it is almost always a subconscious suppression of data. The clinician often already knows the truth of the situation, but they are actively suppressing it because the logistical or emotional consequences of acknowledging that truth are highly inconvenient.
Right.
Or they are deliberately ignoring a vital piece of conflicting information that would force them to abandon a cherished narrative.
It is the exact psychological equivalent of a diagnostic blind spot in surgical practice. You will never find the pathology if you stubbornly refuse to look at the edge of the MRI scan.
Exactly. You only see what you look for.
Right. If a patient presents with a classic history and mechanical symptoms of a complex meniscal tear, but you only order a plain radiograph and refuse to request the MRI because you know you do not have the theater capacity to fix it this month,
That doesn't just vanish.
The tear does not cease to exist. The joint is still being destroyed. You are simply choosing the comfort of willful blindness over the burden of intervention.
And in the context of self-coaching, that avoidance must be reframed. Avoidance is not a character flaw or a failure of courage. It is critical diagnostic data.
Diagnostic data.
Yes. The specific fact that you are so aggressively avoiding looking at a certain aspect of the choice tells you precisely where the core pathology lies.
Well, it points you right at the problem.
It does. If you are avoiding looking at the financial realities of leaving private practice, the finance is the core issue. If you are avoiding discussing it with your spouse, the marital expectation is the core issue, which transitions us directly into question 6, the catalyst for movement. What would have to be true for the answer to be clear?
This question feels entirely different from the others. It feels less like psychological excavation and more like, well, an engineering puzzle.
Because it fundamentally alters the cognitive nature of the problem. It takes a paralyzed, abstract, emotionally saturated dilemma and converts it into a concrete, emotionally neutral, actionable task.
How does that look in practice?
Let us take the scenario of a surgeon debating whether to merge their small, independent private practice with a massive corporate healthcare group. They have been paralyzed by the decision for a year, weighing autonomy against financial security. The emotional load is crushing.
Exhausting.
Then they ask, what would have to be true for the answer to be clear? They might suddenly realize, well, if I knew for an absolute fact that the corporate group would guarantee me uninterrupted block theater time every Tuesday morning without fail, the answer would be an immediate yes. If they can't, it's a hard no.
That is a phenomenal pivot. Suddenly, you are no longer agonizing over your entire professional identity, your legacy, or your financial future in the abstract. You just have one highly specific task. Write a single email to the corporate director and ask for the theater policy in writing.
Exactly. You have identified the single missing piece of data that unlocks the entire architecture of the decision. The overwhelming, generalized anxiety is replaced with a simple, defined data collection task. You have moved from rumination to action.
It effectively removes the existential dread. Those 6 questions construct a powerful mechanism for moving forward. But the literature and coaching notes we are drawing from highlight that providing the right questions is only half the battle.
Only half, yes.
We also have to identify and aggressively silence the reflexive, toxic internal dialogue that actively sabotages this process. We need to talk about anti-coaching.
Yes. Anti-coaching questions are insidious because they disguise themselves as deep reflection. They feel responsible, but they function entirely as mechanisms of self-torture and paralysis.
That's the main offender.
The most common offender is the question, what is the right answer?
Oh, I am guilty of this on a weekly basis. I sit there demanding of myself, just figure out what the objectively correct move is here.
It is a cognitive distortion based on binary thinking. It falsely frames a complex, multi-layered career choice as a multiple-choice exam where there is one single objective truth, and if you pick the wrong one, you fail life.
Right, like there's an answer key hidden somewhere.
Exactly. In reality, for almost all senior professional choices, there is no universally correct answer. There are multiple, highly defensible answers.
Give me some examples.
Staying in the NHS and fighting for your department is a defensible, honorable choice. Resigning to move entirely into private practice to protect your mental health is a defensible choice. Transitioning out of surgery into a health tech startup is a defensible choice.
They all have merit.
They do. The mature question is not which path is universally right, but rather which set of consequences am I most willing to own and live with?
Moving away from the fantasy of the perfect choice and accepting the reality of trade-offs.
Precisely.
The next sabotaging question on the list is, what would everyone expect me to do? Now, I have to stop you here and push back strongly on classifying this as a purely useless or toxic question.
Okay, I'm listening.
Medicine is deeply tribal. In a tight-knit surgical department, or within a specific subspecialty society, social consequences, reputation, and the expectations of your senior colleagues are not just background noise.
No, they're not.
They dictate your daily working environment, your referral networks, your access to clinical resources, and your upward mobility. Isn't it profoundly naive, perhaps even professionally reckless, to suggest a clinician shouldn't deeply consider what the tribe expects?
It is a vital and realistic distinction you are making. Let me clarify. It is not naive to anticipate tribal politics or social fallout. It is, however, disastrous to let those politics become the primary driver of the internal decision-making process.
The primary driver.
Yes. We have to separate the primary driver from the secondary management strategy. If your first question is, what does the clinical director expect me to do? You are immediately centering your entire life trajectory on external validation and the avoidance of social friction. You are surrendering your autonomy.
Right, you're letting them make the choice for you.
You must first use the 6-question framework to decide what is right for your life and your core values. Only after you have internally committed to the path should you ask the strategic question, how do I politically manage the expectations and mitigate the fallout of this choice?
That makes a lot of sense.
Decide your course first. Play the politics second. Do not conflate the two.
That is a crucial sequencing rule.
Yeah.
The decision belongs to you. The communication strategy belongs to the department. Keep them firewall separated.
Exactly.
Okay, the next anti-question. Am I being selfish?
That is simply a guilt loop masquerading as moral reflection. It is rarely a genuine inquiry. It is almost always a rhetorical weapon you use against yourself. If you are asking, am I being selfish? You already feel the answer is yes, and you are using that guilt to prevent making a necessary change. It halts the decision rather than advancing it.
So how do we break that loop?
To break the loop, you must replace the vague, moralistic judgment of selfishness with an objective evaluation of tangible responsibilities. Instead of spiraling into, am I being selfish by stepping down as the head of the training program, you ask a concrete question. Have I fulfilled the specific terms of my contractual obligations, and have I provided a clear, reasonable pathway for a successor to take over?
You transition from a subjective moral judgment to an objective, measurable metric.
Yep.
You either fulfilled the contract or you didn't. You either organized the handover or you didn't.
Exactly.
The next toxic question is one that haunts every major career shift. What if it doesn't work out?
This is a fascinating cognitive trap because it straddles a very thin line between necessary caution and pathological avoidance. It is a perfectly valid concept for pricing risk, but it is entirely useless and highly destructive as a rumination tool.
So what's the difference between the two?
The clinician must learn to distinguish between pricing risk and catastrophizing. Pricing risk is highly specific and quantifiable.
Give me an example of pricing risks.
It sounds like this. If I leave the NHS to start my own independent sports injury clinic, and the clinic entirely fails to attract patients within 24 months, I will have lost roughly 50,000 pounds of capital, and I will need to swallow my pride and apply for a locum consultant post.
Okay.
That is a finite, defined, and fundamentally survivable worst-case scenario. Catastrophizing, driven by the affect heuristic, sounds like this. If this clinic doesn't work out, my entire career is permanently over, my peers will know I am a total failure, I will lose my home, and I will be destitute.
It is the exact difference between conducting a rigorous preoperative risk assessment where you document there is a 2% statistical risk of deep joint infection. Therefore, we will administer targeted prophylactic antibiotics and optimize the patient's glycemic control.
Yes, exactly.
Versus standing in the prep room, having a panic attack that the patient might spontaneously combust on the table.
That's a brilliant comparison. One process allows you to prepare, mitigate, and proceed. The other process paralyzes you with statistically impossible horror stories. And that leads us to the final anti-coaching question, which is perhaps the most deeply destructive of all. Why am I like this?
Oh, ouch. I think every single clinician listening has been there at 3 a.m.
We all have.
Staring at the ceiling, overwhelmed, thinking, why can't I just make a simple decision? Why am I so weak? Why is everyone else managing their careers effortlessly while I'm falling apart?
It is pure, unadulterated self-attack. It offers absolutely zero reflective value. It does not generate data. It does not offer perspective, and it does not map a way forward.
It's just punishment.
It functions solely as an additional heavy layer of emotional distress, compounding the original problem. You are no longer attempting to solve the career dilemma. You're simply punishing yourself for experiencing human friction. If you catch your internal monologue drifting into, why am I like this? You must ruthlessly and immediately halt the dialogue.
Shut it down.
Completely. The self-coaching session is over for the day.
We have mapped out the constructive framework, and we have identified the cognitive saboteurs. But the research we are pulling from makes a very stark point. The methodology of how this internal dialogue is conducted is just as critical as the questions themselves.
Oh, absolutely.
You noted earlier that pure thinking leaves no trail. So if a clinician just listens to this deep dive, memorizes the 6 questions, and tries to run through them in their head while driving to work, the framework fails.
It fails completely and predictably. Effective self-coaching fundamentally requires externalization, specifically through writing.
Through writing.
Moving thoughts from the abstract, formless ether of the brain onto a physical page causes distinct, measurable neurological and psychological shifts. Writing forces absolute specificity. As we discussed, you can hold two completely contradictory emotions in your head simultaneously without noticing.
Right?
But you cannot physically write two contradictory statements next to each other on a piece of paper without the logical dissonance becoming glaringly obvious. Furthermore, writing breaks the circular nature of rumination. It creates a tangible historical trail of evidence.
It goes back to the limits of our working memory. It is the difference between trying to hold a complex mathematical equation, say, calculating the precise multidimensional angles for a complex deformity correction entirely in your head, versus writing the formula out on a whiteboard.
Spot on.
You cannot solve the equation in your head because you're using all your cognitive energy just trying to remember the variables. You can only solve it once you externalize it, step back, and look at the entire shape of the problem.
A perfect clinical translation. And the literature provides strict rules of engagement for this writing process. First, abandon any desire for elegant prose.
We're not writing a paper here.
No, you are not drafting a manuscript for the Bone and Joint Journal. Complete sentences are not required. Bullet points, fragmented thoughts, messy diagrams, and half-finished sentences are entirely sufficient. The goal is cognitive offloading, not literature.
You are just evacuating the working memory onto the page.
Precisely. Secondly, there are practical constraints that significantly enhance the psychological processing. Write by hand.
Really, not typing.
Do not type on a laptop or a phone. The physical graphomotor action of handwriting is significantly slower than typing. This mechanical bottleneck forces your brain to slow down, process the emotion, and structure the logic more deliberately. Thirdly, do it in a consistent physical space. Choose a specific chair in your study or a quiet table at a local library. By returning to the same space, you neurologically associate that physical environment with clarity and resolution, rather than associating your bedroom or your office with stress.
Creating a dedicated zone for it.
Finally, the writing must be strictly, fiercely private. If you have even a subconscious suspicion that your spouse, your colleague, or your mentor might read these notes, your brain will automatically edit your fears to appear more rational, noble, or socially acceptable. Privacy is the absolute prerequisite for honesty.
That makes sense. What is the strategy for reviewing this data? If I write down my messy, fragmented fears on a Tuesday, do I just sit and stare at the notebook on Wednesday waiting for an epiphany to strike?
No, not at all. The review strategy is counterintuitive but critical. Do not reread yesterday's notes before writing today's entry.
Wait, really don't reread them?
Don't reread them. If you review yesterday's anxiety before you begin, you will simply adopt that exact same cognitive pathway and recreate the same anxiety today. You will anchor yourself to the past.
Oh, I see.
Let each session be entirely fresh. Ask yourself the 6 questions anew. Let the patterns emerge organically over a period of days or weeks. Think of it like documenting patient histories on a complex ward around to spot a developing syndrome.
Looking for the trend.
Exactly. A single day's clinical entry might just be noise, a slight fever, a minor change in blood pressure. But 10 days of consecutive notes will reveal an undeniable trajectory of pathology or recovery.
That makes profound sense. You start to see the data points cluster. You realize that on day 1, day 4, and day 9, regardless of what the specific trigger was, you kept circling back to the exact same core fear about missing your children's bedtimes.
The noise fades.
The noise fades, and the actual diagnosis reveals itself on the page. But let us be deeply pragmatic here. Even the most robust, evidence-based cognitive framework has a breaking point. A critical defining skill for any senior clinician is knowing their own scope of practice.
Very true.
Knowing exactly when a complex case is beyond their personal capability and they need to refer it out to a specialist. When do we reach the limits of self-coaching? When do we tag out?
Recognizing the limit of the framework is the hallmark of advanced decision-making, not a failure of resilience. There are clear diagnostic signs that the self-coaching process has run its useful course.
What's the first sign?
If you are diligently applying the framework, writing by hand in a private space, but the exact same 6 questions yield the exact same circular answers week after week without generating a single new insight or action, you are trapped in a higher-order cognitive loop. The framework can no longer penetrate the defense mechanism.
Okay, what else?
Furthermore, if the stakes are existentially high, for example, if the decision involves navigating a complex medical malpractice suit, severe ethical breaches in your department, or whistleblowing, the cognitive load is simply too heavy for one person to carry objectively. You require an external, uncompromised perspective.
Because you're too deep in it.
You're too close to it. Finally, if the decision involves deep, entrenched personal blind spots about your own toxic behavior or communication style that you are cytologically incapable of self-diagnosing.
And I imagine the literature outlines more severe clinical red flags as well, beyond just feeling stuck.
Absolutely. If the indecision is generating persistent, unmanageable distress, if you are experiencing a severe inability to function in your clinical duties, suffering from chronic insomnia, or engaging in extreme avoidance behaviors such as heavy alcohol consumption, self-medicating, or totally isolating yourself from your family, those are blaring clinical alarms.
You need to stop self-coaching at that point.
At that point, you do not need a self-coaching framework or a mentor. You need a licensed clinical psychologist or a psychiatrist.
So, assuming we are not in crisis territory, but we recognize we are stuck and need an external voice, we decide to tag out. The framework suggests we do not necessarily have to immediately hire a formal, expensive executive coach. A trusted peer, a former colleague from a different hospital, or a senior mentor can fulfill the role.
They absolutely can.
But here is my deep concern with that in the medical world. How can a clinician identify if a mentor is actually helping them versus subtly projecting their own unhealed career regrets onto them?
Oh, that's a huge issue.
Right. The culture of medicine relies heavily on apprenticeship, lineage, and replicating the master. I have seen senior surgeons aggressively push juniors to take demanding research fellowships or specific consultant posts, not because it was right for the junior, but because the senior always regretted not doing it themselves.
It is a pervasive and dangerous dynamic in medical mentorship. The lineage system breeds projection. The ideal external sounding board, whether a peer or a mentor, must possess 2 distinct qualities. First, they must be intellectually capable of asking you brutally hard, uncomfortable questions.
Okay.
Second, and most importantly, they must remain completely unattached to the outcome of your decision.
Right.
They cannot have a vested interest in your choice.
How do you spot that?
If a mentor starts a sentence with, well, if I were in your shoes, I would do X. Or if their body language becomes tense and emotionally invested, when you suggest a path that diverges from their own career choices, they are projecting their ego onto your life.
Right.
You need someone who listens to your rambling and says, I hear you saying that you want to stay in academic surgery, but every time you talk about the research lab, your posture slumps and you look exhausted. Why the massive disconnect between your words and your physiology? You are looking for a mirror to reflect your own truth back to you, not a map maker trying to force you down their preferred path.
A mirror, not a map maker. That is the critical distinction to keep in mind. And it takes immense professional and emotional maturity to recognize when you need that mirror and to seek it out without feeling like you have failed.
It does. Having the self-awareness to stop ruminating and ask for the right kind of help at the right time is a demonstration of absolute mastery over the decision-making process.
Let us step back and look at the entire architecture we have built today. We started with that heavy, unmade decision sitting next to you in the hospital car park, draining your energy. We established the foundational truth that hard decisions do not resolve with the passage of time. They resolve with the application of structure.
Always structure.
We dissected why our highly trained clinical brains fail us when turned inward, the compromised jury effect, and the trap of the default mode network. We walked step by step through the 6-question framework, forcing abstract topics into specific deadlines, exposing hidden fears on all sides, bypassing the ego by advising a friend, shifting the time horizon to 5 years to locate core values, confronting diagnostic blind spots, and finally, turning existential dread into a simple data collection task.
A complete cognitive overhaul.
We aggressively silenced the anti-coaching saboteurs, the myths of the right answer, the guilt loops, and catastrophizing. We detailed the precise mechanics of clarity, why handwriting in private is the only way to break the cognitive circle and create a tangible trail of evidence. And finally, we defined the absolute limits of the practice, knowing exactly when to refer the problem out to an external mirror.
And it is vital to remember the ultimate purpose of all this rigorous cognitive work. The goal is not merely to make one single, isolated, good career choice.
What's the bigger picture?
The overarching goal is to reclaim your cognitive bandwidth. Clinicians who learn to successfully process and clear their unmade decisions reclaim vast, previously inaccessible amounts of energy. Energy for their complex clinical work, for their families, and for their own physical health. Carrying the chronic weight of indecision is a massive physiological drain. Achieving clarity, ultimately, is its own profound form of rest.
Clarity is its own form of rest. That is the perfect summation of why this matters. If you found a measure of clarity or a practical tool in today's discussion, please take a brief moment to rate the show and share this deep dive with a colleague who might need it. We all know someone in our department carrying a heavy load right now. I want to leave you with one final, provocative thought to mull over. Think back to that specific decision you brought to mind at the start of this deep dive, the one sitting in the passenger seat of your car. If you were forced to map out your internal dialogue about that decision on a whiteboard right now, would it look like a definitive path moving forward, or would it just be a perfectly exhaustingly worn circle? Grab a pen tonight and find out.